Hi, I'm Dr. Marvin Natevich. I'm a medical geneticist here at the Cleveland Clinic and professor at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. And I'm pleased to be engaged today in some conversation with Dr. Rajesh Kana. He is the Marilyn Williams Elmore and John Doerr Elmore Endowed Professor of Psychology at the University of Alabama. He is also the director of the Center for Innovative Research in Autism at that university. Professor Kana earned his doctorate from the Indian Institute of Technology in Delhi, India. He has extensive training in neuroscience and in neuroimaging from both UCLA and the Carnegie Mellon University. He has been a William Fulbright scholar and has done extensive research investigating various aspects of neuroimaging research and developmental disorders, including autism, and how this research can be impactful in understanding behavior in persons with autism. Dr. Kana has published extensively in the fields of neuroscience and autism, and he's mentored many doctoral and undergraduate students. Thank you, Dr. Kana, for allowing us to have some conversation together regarding your research and your feelings about the field more globally.
Thank you.
Yes. Dr. Kana, many of the viewers of the presentation that you just provided as part of the Autism Research Institute series on autism, many of those viewers are pediatricians, internists, and psychiatrists. Can you give us some understanding why you think this topic is important for those types of clinical practitioners to have some knowledge about?
Yeah, I think one thing to think about is, diagnosis of autism is behaviorally based. So even now in 2023, we are diagnosing autism by using Autism Diagnostic Observation Schedule and Autism Diagnostic Interview. So these two are behavioral observation and interview kind of techniques. They are excellent techniques and they are considered the gold standard in the field. But at the same time, it becomes difficult sometimes, in terms of getting the diagnosis in time. Like many places, there's a long waiting list to get the diagnosis, right? So the average age of diagnosis in the United States is probably about, 5 to 6 years of age. So that kind of delays the path for intervention for many of these children. So neuroscientists are trying to look at, whether we can look at the brain at a much early stage and provide some hint in terms of whether this child will develop autism, or if there is a marker so that we can identify autism very early. So that's a place where probably neuroscientists, radiologists, or neuroradiologists, all these fields which are working in the area of brain and autism can meet the clinic, right? So it's kind of like probably the bridge between those two. So that's one thing which is related to the diagnosis part of it. The second thing is not having a targeted intervention. And most of the children who are going through intervention or treatment for autism is getting treatment or intervention for other features related to the disorder. And part of it is that the syndrome as a whole is more abstract and complex and heterogeneous. But if neuroscience and neuroimaging can identify some target which can be addressed in treatment, so that can be more targeted approach to that. So I think these two are the domains. One in terms of firm diagnostic markers. Second, identifying a potential target for treatment and intervention. Those are the places where neuroscientists kind of take steps to meet the clinician, more like basic to translational kind of research.
So it would seem to me to be a lot of practical considerations in terms of having neuroimaging studies done, especially on a large scale, for the very large numbers of persons who have a form of autism. Can you explain to the viewers what are some of the just practical considerations for, say, infants or young children and for adults in terms of having a neuroimaging analysis done?
Yeah, it's a lot. There are a lot of practical considerations to think about. First of all, if we take children in general, like pediatric neuroimaging itself can be difficult, and then neuroimaging with autistic children can be even more difficult, right? Part of it is that you are in this scanning environment, where you have to be still for a longer duration of time, and sometimes you're asked to do tasks within the scanner too, and that can be a tough environment for a child. On top of it, a child with a lot of sensory sensitivity associated with them, like some children may be affected by the noise of the scanner. Some may not like the feel of certain things on their body, like the coil or the blanket or anything related to the whole process. So there are many challenges associated with getting a good usable data from children in general. So those are the quick things which I can think about. And of course, from a researcher point of view, it's an expensive endeavor too. Like most places, scanning a person for an hour costs about $600, $600 to $800, I would say, plus subject payment, like the money you need to pay for the participant. So put together, you're looking at probably $800 to $1,000 per participant. And that's not an affordable thing for many labs to do. And some of these has real implications on the data and the papers which we see in the field, because many such studies can be underpowered. Like maybe a lab may not be able to afford 100 participants in their study, may publish with 25 participants, but that may not be enough power to see a reliable finding. So some of these are major challenges in working with children, but there are ways to go around some in preparing the children to do these tasks too.
So from a practical perspective, are there subsets of individuals who need specific types of preparation? And if so, what types of preparations do you have, like mock MRI scanners or other means for certain types of individuals who might benefit from a pre-scan, for example?
Yeah, we try to do that preparation with every single participant. It's better that way than asking specifically a certain subgroup within there. So it starts with a social story. So we created a picture story about the day of the scan. That's called social story, like my MRI day, and it'll have every single step that child or a person will go through during that day, including the picture of the person they are meeting, the building, each step-by-step thing. In that way, one thing is that they, in advance, are able to go through the entire process, get a picture of those. Many autistic individuals prefer structure to the T, so that helps them plan and organize their day really well. The second thing which we do is we record the noises of the MRI scanner and send it to the family beforehand and tell them, play these noise to the child, and so that they can get acclimated to the whole process of scanning. So that's another thing which we do. And of course, we also do a mock scanning drill before. Sometimes we also do a 15 minutes just going in the main scanner, the actual scanner, and just lie down there, and then come back and then take a break and then get ready for the scan. So all these are different preparations one can do in terms of getting them in the scanner. Also, we can pepper it with some breaks in between. We also do one very interesting thing. We decorate the scanner with all the interesting toys, and we stick those toys onto the scanner and create a kind of like a different world, like a spaceship, or an animal area kind of thing, like with lots of animal stickers and things like that. And then the blanket changes from white to a colorful blanket, So all these things can contribute a little bit to the child getting adjusted to this new environment.
I see. Thanks. And, we don't clinically apply MRI across the board to all persons with autism. We're very selective clinically, in contrast to, say, research efforts to use different types of MRI to learn about autism. When you presented information about different either functional changes or structural changes in brain that can be seen in persons, generally speaking, with autism compared to appropriately matched control subjects. Are there biases in subject selection in the research world that you see and that have to be thought through that may limit generalizability of some findings?
Yes, it's such an important and interesting question. So there's a lot of bias, I would say, but some of them are not like specifically the researchers want to recruit. Like for example, most of the MRI studies will have what we call higher functioning autism. I don't know whether we should even call that. Like we all have an IQ cutoff, for participating in these kind of studies, And part of that is, to make sure that they can adjust in the MRI scanner. It's a challenging set of things they need to do there. And then they can be there and then do these tasks, like be it sentence comprehension or problem solving, any such things, So there itself, we are taking probably the higher end of the spectrum of participants there, and ignoring to a certain extent the other part of the spectrum. So the rationale behind that is that, okay, these individuals can do the scan, and if we find something different about these brains, maybe that is more in the other half of the population. That's the logic behind that. But at the same time, we are biasing in terms of taking only that sort of sample. The other I would like to mention is sex differences, right? I think roughly the ratio of male to female in autism is about like 4:1. So most of the studies, even we actively try to recruit, females, but the ratios are pretty skewed, right? So we would see if you take 100 participants in a study, very likely that 75% or more are males there, and then the rest is the females in there. And I think many labs, including ours, is trying to address these differences with some techniques. Like we are trying to use a technique to simulate the females in the sample and create more data just to see whether increased sample size in that category is showing a difference, from not having that, so those sort of things.
Yeah, I see. Yeah, and along that line, from a clinical perspective, we are very aware that the nature of clinical presentations and clinical natural histories for autistic individuals vary enormously. And there's a saying in medicine, if you've seen one autistic individual, you have seen one autistic individual. And you very nicely in your presentation talked about the issue of the scientific issue of dealing with heterogeneity. From a genetical perspective, and I'm a medical geneticist, while in 2023 we are not able to determine the underlying etiology of autism in a majority of persons that we see clinically, we do know that there are more than 100 definite causes or major contributing factors to causation of autism, although most are either uncommon or frankly rare. So we know that there's a lot of underlying etiology, not only in terms of clinical manifestations, but also in terms of underlying etiologies. And you spoke of this in your presentation. You talked about the complexity. Can you elaborate a bit about this more and how there might be research strategies to either subtype or otherwise deal with the very known finding of both clinical heterogeneity and underlying etiological heterogeneity?
Yeah, and another important question, and I think the heterogeneity is a major factor. Like, we usually say, just like you mentioned, the only similarity between two autistic individuals is that they are different, right? So that's sort of a difference you can see in terms of the manifestation and adjustment to the disorder too from individuals. So we see a lot of complexities there when we in the participants which we are seeing too. As I mentioned earlier, like you see a big IQ spread. Like you can see a child participating in a study like ours with an IQ of like 75, but there could be a child with an IQ of 140. So,
and I would imagine also there are medical co-occurrences or co-occurring medical conditions that you see in more than half of persons with autism. And in the most perfect research world, I think one would want to control for gender, cognitive capabilities, a number of behavioral phenotypes, as well as medical co-occurring conditions. So it'd be very challenging, especially when you overlay on top of that the research interest in having an adequate N.
Yeah, exactly. It's really challenging, and I think you addressed some of those main points there, that you will see this like different ends of the spectrum in there. Comorbidity is a big issue there. Lots of autistic individuals will have an ADHD diagnosis along with that, right? Or many other disorders too. So if we ignore some of these things, another thing to point out there is medication. The kind of medications they take, how long they have been taking the medication, the kind of interventions a person receives. So I think all these adds to the complexity of the data which we all are collecting. And some of these have direct implications on the data we are collecting too. Like the medication they are taking may have an implication on the MRI signal or their performance in the scanner. That could be a factor too. So many studies may be ignoring all these, and I'm putting all my autistics into one bin and controls into one bin and doing the comparison. And I think as I talked about in the talk, that may be the problem. Like many effects may be washed out as a result of that, or you may be seeing inflated effect as a result of that. And I think one way to approach this would be to delve into the data deeper and then look at and identify how subgroups are there within that, and whether the subgroups are influencing the data and so on. One practical hurdle with many of these things is the publication world. Like when you do the subgroups, your number further dwindles into smaller groups, and then you can be questioned in terms of the sample size with the publication, right? So I think that's where we probably, as researchers and reviewers of papers and journals, need probably a broader outlook. And sometimes it can, like a smaller study can be more informative and influencing the field than a larger, with the entire group in one category. So I think, some of those efforts may be needed to look at data more individually and to identify subgroups.
And in your area of research, what is the general landscape of this type of neuroimaging analyses for adults with autism? Are adults included in many of the studies, or is it more skewed towards children or babies?
Adults are included in many studies. I think, especially neuroimaging world, there are lots of adult studies. And like we have done a lot of studies in our own lab too with adult participants. Part of it is it's easier compared to scanning children, and the control groups can be recruited easily with that category too. So there are many practical aspects related to adult studies, but sometimes it may not be as informative as children. But I think I would say more are in the children and adolescent kind of category than adults, but there are many studies. And now I think, there are also studies in the older adult category to look at, what happens, at a later stage in life with many of these individuals.
Yeah, I'm really glad that you just mentioned that, because that is certainly an emerging area clinically. The number of persons who are senior with autism is not trivial, and the state of knowledge from a clinical perspective regarding the different types of co-occurring conditions and natural histories of those conditions in elderly individuals who are autistic is the state of understanding in 2023 is very, very limited.
Yeah, it is.
And so I would hope that this would also be paid attention to by neuroimaging research as well, to study brain function by those means.
Yeah, I agree. And I think there is a lot of effort from different labs, to identify older adults and study that population. I think that'll be telling a lot, because you need to look at the developmental and other declines associated with age, and then you have to see how much of autism is in there in terms of like influencing some of these things. And I think the field can probably tell a lot of and learn a lot from that population, I would say.
Yeah, part of your talk also that was very interesting had to do with developmental plasticity. And certainly it's the hope for many that certain types of conditions you can have plasticity such that there can be amelioration or clinical improvement of the condition. And you illustrated some really interesting basic science work with songbirds, for example. And for sure that would be the hope of some individuals and their parents to have amelioration. I think it's also important for us to acknowledge that there are some persons who have autism who do not view themselves as having a disorder whatsoever, and they proudly identify as being autistic, and they wouldn't want to have an intervention. So there are clearly differences of thought about how to consider being autistic that we need to be aware of. But it's very interesting that you were able, and you and the others in the type of research that you do, are able to show functional MRI changes with some types of intervention for those who potentially might benefit from intervention. Can you elaborate on the types of directions the field is moving now?
Yeah, I think, I couldn't agree more with, this, and we discuss in our lab occasionally, and these days, more frequently about, the neurodiversity, movement, and whether like treatment or intervention or changing is needed, right? So many people even don't need that, right? And also to conceptualize some of these things, what does it mean, right? When we say an activity pattern is changed or a functional connectivity pattern is changed, right? It's basically nothing but how the brain is solving certain problems in a different way or the other, right? So that's exactly the way it is done. So I think there is a subset of population within autism who don't need this at all, actually. But there are people who would need this as well, and I think there is more, care given by researchers to meet these, not necessarily needs, but the point which they are raising. Like people are more appreciative of it to implement that in the research, for sure. And a couple of things to specifically to point out is that I think with some of the fMRI studies, with people who need not necessarily treatment, kind of like a direction, like face processing studies, which I was talking about earlier. Like many face processing studies showed lack of activation or poor activation in fusiform face area. There are also studies, where they gave specific instructions to participants to where to look when they are looking at those faces. Those kind of studies showed very specifically fusiform activation in those autistic individuals. So clearly tells that, sometimes, a person may not be looking at a certain thing, the exact place they want to look at, so it may not be a social problem they have, it may be a perceptual thing where they are looking at, right? And with that simple direction, you can change a pattern of activation in there. And I think, if you take a step back and try to look at intervention-based neuroimaging studies, I think that's what probably we are all trying to do, just to give that direction that you can reach language comprehension in a better fashion by going through this strength which you have, right? And accordingly, you can see some neural changes associated with that. That's what we are trying to do that, And I think, you don't need that at all, because there are lots of compensatory strategies probably in more functioning individuals, And you can see that also in girls with autism, right? Autistic girls, many of them, there is this idea called masking, right? They can mask some of the symptoms, because of their functioning level, their language development, social interaction, and so on, actually. So I think, yeah, one has to be really mindful of, who needs and how we pitch this, whether it's a treatment or intervention or just a direction sort of thing, Yeah.
Mm-hmm. And for the pediatricians, family practice docs, internists, psychiatrists, and other viewers of this session, are you able to sort of distill what you would consider the most important take-home messages from neuroimaging research on autism to date, and give the viewers some sort of idea about what the needs of the field are and where you think it's moving, either research-wise or perhaps even clinically, because certainly imaging is not applied very widely in persons with autism at this moment in time.
Mm-hmm. I mean, I think traditionally science in general, and autism-related fields especially, there has been a cutoff from the basic research to more translational and clinical kind of work, right? So I think in the last several years, and I think there is a conscious attempt to build this bridge between clinic and basic research, and I think that's where I would say one of the, if you look at the many neuroimaging studies in the past maybe 5 or 6 years, there is a very conscious attempt to take it to the next level rather than just another activation study or another connectivity study, that how can we take it to a level which is beneficial for somebody like a pediatrician or a clinician who's seeing these individuals on a daily basis, And that's where some of these applications to machine learning sort of techniques, comes in, that can we push it to the, level of, I shouldn't say diagnosis, but classification, right? So that if there is a case which is borderline or maybe difficult, maybe this MRI can provide an additional information, in addition to and beyond, whatever techniques, which are used in the clinic, in terms of diagnostic support. And I think that's where the goal. The second part is more like in a precision medicine sort of approach, can you look at more like a white matter fiber bundle, right, of an infant, and predict that, this child would, or this infant would benefit from this kind of an approach in terms of education, in terms of, or a certain intervention. And there are studies in the field going on like that, looking at specific fiber bundle which is involved in reading, and then designing an intervention that this child would benefit from that. And that's something which we are seeing in our own sample too, that not every single child benefits from the intervention in the same way. So there is a huge difference in that. So those are the two places which kind of like, and I try to put in there in terms of diagnostic utility and intervention potential. I think that's where the field is slowly walking towards the clinic. So I would say the next 10, 15 years, we would see significant changes in, or hope to see significant changes in that.
Well, thank you so much for giving us a really insightful lesson.
Thank you. Thank you. I appreciate it.